up to about 750 mil. And when we look at some of our more simple fractures, if you did a fractured humerus, chances are you could lose about 500 to 750 mils just in that area from a simple fracture. At that stage, patients got normal vital signs. Okay, when we move into class 2, so the patients have lost 750 to 1,000 mils, that's when we're starting just to see some very, very subtle signs of the fluid loss with them. So we're seeing starting tachycardic, they're starting to get a feeling of slight anxiousness just because there's a little bit of hypoxia that's starting to go on because of that circulating volume being decreased. Class 3, which is 1,500 to 2,000 mils, think about your patients with a shaft femur fracture. It's not unusual for them to be bleeding within that space, 1,500 to 2,000 mils from that fracture. The signs and symptoms that we're going to be starting to see because the body's trying to compensate is they'll be starting to get tachycardic because they're really reducing all that yak output around the body. They're trying to get all of that oxygenation happening. They may be starting to get, not very good spelling there, but hypotension at that stage because they're starting to get hypoxic. What's happened is they're getting a feeling of anxiousness, agitated, and they're confused. Okay, but there's not really a lot of signs and symptoms at this stage. It all really is quite, it is, quite subtle, the changes, even though this person is compensating and they could be in trouble in a real hurry. Okay, when we look at more than 2,000 mils, okay, so think of again, it may be a shaft of femur fracture, it could be an open fracture. The ones straight that come to mind is pelvic fractures where you've got all the major vessels running through. They could be losing all of that blood retroperitoneally, if that's a word. That's when they're starting to not compensate quite so much. So all of their compensatory mechanisms are failing. Patients going into shock. So you're starting to get bradycardic, hypotension. That's when you're getting your decreased GCS. And patients really lethargic. Okay, and it's not an accurate thing because we know that there are several stages of shock, but it is something as quite a good guideline and something to remind us that even though they've got normal vital signs, they still can be in really quite a compromised position and we can have an emergency on our hands fairly quickly after that. Keeping in mind younger patients and a lot of our trauma patients, you think about the profile of trauma patients, young, fit, healthy, under 24, under 30. In a lot of cases, they're males. Their compensatory mechanisms are usually very, very strong. And so what's going to happen is we're going to see the signs and symptoms a lot further down the track with them. Children's another one. If children are coming in, they compensate for a really long time. And what will happen is by the time we're seeing signs and symptoms, they're going downhill. They're going to crash on us very, very fast. Okay, so they just keep that all in mind with circulation and blood loss. Okay, the next one, we've done A, B, C. We move on to D, which is disability. So looking at their neurological system, assessing their Glasgow Coma score, looking at their pupil size and reaction, and posture and movement of limbs to relating to that as well. So we're looking at this stage, do they have a spinal injury? Is there paralysis that is happening at this stage? Still haven't even got to our fracture management yet because that's further down on our list of priorities. Next one, E, and what that stands for is exposure. So exposing the patient from head to toe so that they can have a look to see if there are injuries, and also environmental control at the same time. So making sure that we're keeping those patients nice and warm. So exposing the patient, log rolling at this stage, unless there's an obvious pelvic injury, but what they want to do is have a look at their back, check down their back to see if there's any obvious fractures, see if there's any obvious injuries that we couldn't see that they were lying on. Okay, so once they've done that, some of the adjuncts that probably would be happening at the same time, depending on the setting that you're working in, but would be, if possible, a trauma series of x-rays, Putting in a nasogastric tube. Quite often trauma patients, doesn't necessarily happen that they have an empty stomach. So what we're wanting to do is try and prevent them from vomiting and aspirating. So we'll be putting in a nasogastric tube and putting that on drainage or aspirating if need be. And certainly if their conscious state is down, that needs to be done. Also, it just, decompressing and allowing them to, if they've got a full stomach, allowing their respiratory system to work a lot better if there is a bit of decompressing. Also putting in a urinary catheter, not only to control their bladder, but at this stage, we're needing to know very, very closely what's happening with their fluid balance. When we look at that chart beforehand, where the signs and symptoms of a patient going into shock or volume loss are really quite late, one of the much earlier signs that we may be able to see is that drop off on urine output. Okay, so if we're able to assess that nice and early, we're able to get a nice early sign that that patient's going into trouble. Okay, secondary survey. One of the nice little mnemonics that they've come up that our ED colleagues tend to use is AMPLE, and it's things that we need to know about a trauma patient. And if possible, if someone's with them or if the patient's conscious enough to be able to let us know, we need to know their allergies, we need to know what medications they're on, we need to know their past medical history, last meal that they've had, and the events and the environment related to their injury. Okay, for trauma patients come in the middle of summer and, they've been trapped in a car in the heat, on a 35-degree day for an hour before they've been able to get them out, they're the sort of things that we need to know. If they're in Perisher at the moment or in the eastern states, they've been out in the cold, certainly they're things we need to know because they need to be things that we can address. And, if we can find out with the events and the mechanism of injury, that certainly helps as well. One of the great things now, digital cameras, everybody having mobile phones, makes it a lot easier to be able to get photos from the actual trauma scene. Okay, if any of their friends walk in the door and they've got a phone, ask to see them. I know certainly St John's Ambulance are tending to use cameras a lot more to get photos to be able to show the staff as they come in so that you've got much more perspective from the accident. And our paramedics in the helicopters, we've got the RAC rescue helicopter over here. Again, they're putting together the photos with the documentation that they're bringing in so that we have more of an understanding of the forces that have been involved. Okay. Now, secondary survey, looking, as we said, a complete examination from head to toe, checking their head and neck, checking all of their chest and abdomen, checking their back. Finally, we get to their limbs, okay, the bit that we all like. We look for bruising, deformity, tenderness, look at the neurovascular integrity. We get to have a look at the function and also, peripheral nerves to see if there's any damage. And we've got a lovely little photo here which highlights the important things that we see. Okay, so that left foot that's lovely in purple should be jumping out straight away at us and telling us that we've got an orthopaedic emergency here on our hand. What this was a patient who came in with a knee dislocation, and as quick as possible, as we know, that's a real orthopaedic emergency because, the femur and the tibia are completely apart. And so all of those popliteal vessels have all been kinked within that. That's been enlocated, but we can see that we've on the left there, sorry, it's right on the screen, his left. His left. We've got a lovely dusky foot that really needs to be addressed pretty much straight away if we can. What we do know about our neurovascular status, important things to remember. Nerves without a blood supply, they start to be damaged within 30 minutes, and that damage is irreversible in only 2 to 4 hours. Okay, 2 to 4 hours of blood supply, there is a limb that is no longer functioning. Muscles are a little bit more robust. What it is without a blood supply, after 2 to 4 hours, that's when they'll start to be damaged, and it's irreversible after about 6 to 8 hours. What it does say is, we've got a little bit of time to work there, but, if their other body systems are allowing, we're wanting that to be corrected as soon as possible. Okay, the adjuncts to secondary surveys, specialised diagnostic tests, depending on whatever your clinical assessment has found, then we want to back it up with some of our tests as well. And that would be where we're working and what we have available to us. But certainly radiology, CT scan, MRI, if patients are well enough to have that done. Okay, and that's when we also start thinking about their analgesia or antiemetics. Again, we think about preventing aspiration in these patients. And getting patients stable enough to be able to transfer them into the CT scan. We think about how long a CT scan actually takes. If they're too unstable, even though that information is just so valuable for us to get, we need to have that patient stable enough to be able to have them lying on the scanner, not getting as much input for us for that 15 or 20 minutes or whatever it is going to take to get those films. Okay, they used to have a saying in ED, death by CT, because a patient will be put in for a CT scan who wasn't actually stable enough to be in there for that time. And that's not a trap that we want to fall into either. Again, we want to be aware of shock. We talked a little bit about hypovolemia, but also there could be an cardiogenic shock or also distributive shock through your neuro shock. And a little bit later along the way, not necessarily initially, but being aware of septic shock as well. We did have a patient looked after at Royal Perth quite a few years ago, and she had was 15 years old. She had what we thought was a really quite simple lumbar fracture. She'd been admitted overnight to the ward, and about 7 o'clock in the morning, this is when things quite often happen, isn't it? She'd been stable all night, no problems with her obs at all. But when the nurse was in there talking to her, she felt that she was a little bit drowsy. So she got me in to have a look. Within about 20 minutes, we had a full resuscitation on her hands, because what had happened was at the time of injury, she put a little nick into her bowel that we didn't know about, and it hadn't been picked up. So she had all that leaking out of her bowel, and what we were seeing was a picture of septic shock straight into there, and not just a simple lumbar fracture. Being 15, she compensated for a long time, and then when we saw her, she was starting to go through her decompensating stage. Luckily, she could be resuscitated. She was transferred down to our rehabilitation and left the hospital in one piece, which was great. She was also lucky enough not to have any spinal deficit, but it could have been a very different way for her. Okay, we finally get to the orthopaedic management, and this is going to be a little bit of a walk back in history with some of our patients and why we do what we do. Okay, historically, the way for the multiply injured patient is involved considerably. I even think about within my nursing time, and I'm a little bit of a dinosaur, but not that old of a dinosaur, but can remember, as we said in the last thing, nursing most of our orthopaedic injuries within traction when I started in an orthopaedic setting. Not long afterwards, we saw patients mainly going to theatre, getting internal fixation done for their fractures, and certainly for the multiply injured patients, there's been big changes within our care. Initially, because they've known about fat embolus for many years in orthopaedics, for the 20th century, the feeling was that the patients were considered too ill to undergo surgical procedures. They worried if they did anything with these patients, they were going to send them into fat embolus, and they were just too ill to operate on. There weren't many techniques available for them, and fracture fixation ways were few. It was believed that early manipulation of fractures was contraindicated due to that fear of fat embolus that they had. Okay, over the first half of that 20th century, that's when they started looking at different methods of traction to try and keep the fractures immobilized, because they identified that by immobilizing fractures, they were starting to prevent some of that fat embolus. And I don't think we had anyone here for the traction session, but the routine introduction of the Thomas splint, when that came through, which was in World War I, reduced the mortality rate from femoral fractures from 80% that were dying from them right down to 20%. Okay, so it was a really, really successful thing getting that Thomas splint in, which is still very, very similar to the Thomas splint that we use, and they were able to reduce mortality in a significant way. And that's just an example there of a Thomas splint. That's a school one, and you know, certainly, as I said, when I was first working in orthopaedic wards in the late 80s and early 90s, we were seeing that as a commonplace management of fractures. However, they weren't without problems. And what we realised bit by bit was those long periods of recumbency led to patients who were getting all the immobility complications, such as pneumonia. They were getting DVTs, some were getting PEs, all that muscle wasting that was happening because patients were in bed in traction for 6 to 8 to 10 weeks, and also the decubitus ulcers. So we realised it wasn't necessarily the best thing, but there were not necessarily alternatives at that stage. And a big part of the nursing care was trying to prevent and to manage those complications. In the early 70s, that's when a lot of the fracture fixation techniques started developing really quite rapidly. And it became evident that early stabilisation of the fractures was yielding a much better outcome for the patients. And that by early getting in, immobilising them by fixation, that was reducing the incidence down of fat embolus. So patients were being operated on very early. They also started to realise that getting patients up and mobile a lot earlier is leading to less complications for the patients. And there was a couple of studies in the 1980s which were able to demonstrate what they felt actually true. First one was by Johnson et al. By saying just by delaying theatre for these patients of stabilisation, they were seeing a 5-fold increase in fat embolus and patients going into ARDS. And I love this name for an orthopaedic trial, but it was one of the really big trials at the time. It was by a gentleman called Bone et al. And they did a prospective randomised trial to have a look at patients that were going in for early versus late fiction of femoral fractures, and that was the really definitive study that I found was very convincing that that was the way to go. So at that stage it was called early total care. So not only patients with a simple femoral fracture, but your multi-trauma patients as well were going in straight away as early as possible for early fixation. Some of the benefits that they felt at that stage, and they are true, is patients usually experience deterioration in their general as well as their respiratory condition in that first few days after their injury. Okay, we've obviously got the injury, we've got our physiological reserves right at that beginning part of it. We haven't started to go into any complications. That may be the best that they get until we're able to correct. They're going to probably get a little bit worse over those few days and then start to get a little bit better, hopefully. The early fixation helped with pain relief. At that stage, in most cases, we're probably in our optimal nutritional state. I mean, again, maybe some of the oldies not so much, but you think about your trauma patients in general, and you know, we said already in a lot of cases they're quite young patients. They may be in their optimal nutritional state because their body hasn't started using all of those reserves for their healing. Also, they're not yet colonised by any nosocomial organisms within that state. So the principles there are really quite good. The only problem was they started noticing that there was quite a lot of the patients that were severely injured and the multiple trauma patients were still not doing really as well as they were hoping. And a lot were going into particularly respiratory complications with that. That's when there started to be concern about the stage that they were reaming and doing intermedullary nailing in patients, particularly patients that had thoracic trauma and were already colonised with their respiratory system. What they were finding was there was quite a lot of them were having a really poor outcome, and so that's when it started to be quite controversial. Okay, and we now know through the reaming of the intramedullary nails, there's all that stress response that's happening. There's all of that fat that's also going into the areas for their reaming. So what they did was the concepts changed a little bit. What it was leading a gradual move away from that immediate definitive fixation of the major fractures to then doing contemporary fixation that they could do really quite quickly, and resuscitation followed by definitive fixation once we knew that their condition had stabilised, and that was known as damage control surgery. So what we're seeing at this stage is the external fixators coming in that can be put on really quite quickly. That fracture can be immobilised, can be held together. We can then look after the patient for those few days, make sure that any other crises that are happening have been averted, manage their respiratory system, manage whatever other injuries they need, and then when they're well enough, we can come in and do the more definitive surgery that's going to fix their fracture properly. Okay, now damage control orthopedics is done in 3 stages. First of all, that early temporary stabilisation, for example, by an external fixator. Resuscitation of the patient, not only literal resuscitation, but fluid resuscitation, antibiotics, body systems being managed, any comorbidities being managed for them. And then when they're convinced that they're well enough, that's when they go back into theatre and have the definitive fixation of their fractures done. It's a little bit of an old photo, and we wouldn't see external fixators that look like this on a pelvis, but it's a good example there. We can see that at the same stage, patients, had something abdominal going on there as well. It has been fixed at the same time, but it's lovely to sort of have that fixation on, and then they can come back and do something a little bit more definitive and fix that pelvic fracture a little bit better once the patient's well enough to do it. Another example of that is with a lovely open tibial fracture that we have here, that there's, the fracture's immobilised really quite well by that external fixator. We know that we've got soft tissues there that really need addressing. Risk of contamination, you certainly can't do internal fixation of that, otherwise you're asking, for a really bad infection and a very septic patient on your hands. One thing I will point out, and I've got a little box on my screen, so it's a little bit hard to do, but certainly the area and zone of injury is really quite obvious initially where that has already been debrided once. But when you look at all of the tissues that are surrounding and down through this area, thanks Paul, we can see a real duskiness starting to come out in that, and that is flesh that is not viable either. So, that's going to be needed to be reoperated on, redebrided. They have a little second look at that in theatre, and that's going to be needing debriding as well. Okay, so what they can do is address all of those soft tissues, obviously antibiotics for this patient, debriding away all of the devitalised tissue, and then treating those soft tissues to be able to get a bit of healing and a little bit of coverage. Webmaster strikes again, yeah, he does. Yeah, and possibly a muscle flap, back dressings, and then come in and do more definitive fixation of that fracture. Other things that changed within the 2000s, we had much better understanding of the stress response and how the stress response to trauma starts working in our body. And that's, stress response that from anything, we've got a fight or flight that's coming in with our adrenaline and our noradrenaline from our autonomic nervous system. We've got the cytokines that are all put in, the immunological responses that are happening, the coagulation responses, which is to protect our body from a stressor. But when you've got a major trauma that's happening, that stress response is amped up and up and up, and it starts doing damage to our body, and in particular our lungs. So think about all of those cytokines, all those things that are flooding through our body through our stress response. They can be really quite toxic to our lungs. Our lungs become a lot more permeable, and that's when you've got, they've discovered that there was a link from this stress response, even without a chest injury, to be able to go into ARDS and have a pulmonary insult from our actual stress response. And with that, we understood a bit more about the systemic inflammatory response syndrome, where that response becomes so much that we start to get lung damage, we start to get multi-organ failure from it. You think about our kidneys. all of our stress response is happening. It's shutting our kidneys down because it's trying to shunt all of that volume back through the rest of our body. But we start to get the renal damage from that as well. Everybody has a different stress response within your body, and obviously the more major the insult, the bigger the stress response is. But they can now measure individual stress response in people by our interleukin-6 to discover what part of the stress response we're going through. At the same time, what happens is body says, okay, the stress response is happening. We need to calm that down, so you get that compensatory anti-inflammatory response. But what that does is that dampens down all your immunological response so that you're actually really prone to infection, sepsis, all those sort of bits and pieces. And that's a whole talk itself, really, stress response, and it's something that they would see within the critical care areas. But it's important that we realise that all of that is happening within our patients to a certain extent. What they also discovered was the concept of second hit. Not only does the injury or the insult cause a stress response, but also what we're doing to our patients is causing stress response as well. So second hit is the medical interventions which can be thought to be additional trauma on your body. For example, patients going to surgery. Surgery has a lot of effects on the body. All of those are a second hit. Okay, so if their physiological reserves are under a lot of stress from that trauma, and then we put surgery on the top of that, is that going to be too much to overcome their physiological reserves? Okay, so they understood the process of second hit. Now, where we can use that to our advantage is again saying about this interleukin-6. If they can measure the level of that in the blood, it can tell you, right, what level is your stress response at? Is it safe now for us to be able to take this person to theatre? Okay, so we've talked, initially about they've put the fixators on, that stress response is sort of happening. We can test the patients along the way to see if all of that has calmed down within their system, and then make a decision when to take them back to theatre. Okay, so they understand a lot more about that now. To date, they haven't done a randomised control study relating to the effectiveness of it. It's just very much that they feel that this is the best way to go and that they're seeing a lot better outcomes with the patients. So I hope that all makes sense. We're going to move on now to the nursing management of our multi-trauma patients. And most of it is our really good general nursing care and keeping a really close assessment on our patients. So looking at their oxygenation, monitoring that as well, looking for signs of hypoxia with our patients. One of the earliest ones will be changes in their behaviour, and it can be really quite subtle, such as a little bit of agitation with the patient, restlessness. I've had cases where patients have been hypoxic, and what it is some of the relatives have actually said to you, look, they're just acting a little bit differently, they're a little bit strange, they're not necessarily themselves. There's nothing on their vital signs to be able to tell you that, but certainly if relatives are telling you that, there's no harm in getting some ABGs done and finding out what's happening with that patient. And again, with our respiratory, being mindful of the effects of immobility within their respiratory system. Cardiovascular, monitoring for their signs of hypovolemia, and again, keeping that little chart in mind that just because your vital signs are fine doesn't mean that that patient is fine. We need to be keeping a really close eye on it. Restoring any of the volumes that they have that are missing, keeping a really accurate look of their fluid balance, because that's going to be one of our very early warning signs to say that a patient is compromised. And keeping in mind that risk of thromboembolism. And as I said, I really do recommend Paul's presentation on that that's already available on the ANZONA site. Again, all just really, really good basic nursing care, looking after their genitourinary system and their gastrointestinal. So looking after their catheterization, their nutritional needs, and think about how much protein and things are going to be needed by the body as part of that healing process, and keeping a close eye on bowel care, because if they're compromised, it's smaller stresses like that that may be really putting their body under, and it's just too much for their body to cope with. Musculoskeletal, looking after their fracture management, managing the edema. So thinking about just our good old elevation that we can use of fractures, and immobility if they're fractures that haven't been fixed. Managing whatever treatment modality that they've had, such as an external fixator, if they've had internal fixation done, and there's small chances that they are in traction, looking after that as well. That early detection of any complications that they could be having, and the importance of pain relief, okay? Because patients in pain, again, we're going to get that stress response happening, and that is going to be compromising them as well. Apart from the fact that just being in pain is just something that we just do not want from our patients. You think about their respiratory systems, if they're in pain and they're not breathing for us up properly because they're restricted by that pain, certainly that needs to be managed for them. Looking at their neurovascular assessment, making sure that they're not getting any pressure areas, observing them for any signs of infection, managing any of the soft tissue injuries that they have, and certainly now that we have the vacuum assisted dressings, that's certainly helping a lot with that. Doing range of motion of their limbs to make sure that we're trying to keep that for them. And also psychosensory, with our conscious patients, making sure that that's addressed as well. Okay, when they're elderly, and quite often our trauma patients aren't necessarily the young 24 and unders, but trauma does happen to our elderly patients as well. What happens is things such as falls, they're hospitalised for trauma at twice the rate of the general population. So we have that big spike of the 18 to 24-year-olds, and again we have that second spike in our older patients as well, coming in with trauma. It's being aware of a lot of the physiological changes that has happened to their bodies, the pre-existing medical conditions that they have, because it is quite rare for them to come in without a comorbidity within that age group, and also their physiological reserves that they have, which may be compromised even before the trauma has happened. Some of the common sort of injuries that we have, rib fractures, C1 to C2 fractures, and they tend to be extension injuries from falls. For example, if they hit their chin on the side of a bathtub and they extend back, it's quite common to see that. Subdural hematomas, hip fractures, and Anita will be pleased that they've got a mention, and also fractures of the radius as well. They're really quite common due to the osteoporosis within these patients. They can come in as a complete multi-trauma patient, just the same as our younger patients as well, but they are very, very tricky to manage. Again, the prioritising of their care is exactly the same as the younger patients, that we're starting with our ABC, but there's a few things that we need to be aware of as well. First of all, with looking at their airway, looking at the presence of dentures or also brittle teeth that may potentially obstruct within their airway. The other thing, their vital signs can appear normal when their patient's quite compromised, because what's happening is their compensatory mechanisms that should be kicked in, like their cardiac output being increased or their pulse rate being increased, they're a little bit slow for the bodies to be able to do that. They don't sort of kick into those compensatory mechanisms in the same way. So quite often, from their point of view, their vital signs can appear normal when patients actually compromised. Being aware of what medications they're on. If they're beta blockers, you may not be seeing the tachycardia in them as well, and finding out whether they're on anticoagulants. They've got much less tolerance to hypoxia, so the hypoxic changes are going to happen a lot quicker with them. Cardiac output may not always increase to try and meet the oxygen demands of their body. They don't tolerate hypovolemia or hypervolemia very well as well. And again, it has to do with their cardiac system, maybe not functioning in, the optimal way that we'd like it to be functioning, to be able to address. And with impaired renal function and their glomerular filtration may be a lot slowed down to be able to respond to that as well. Neurological examination, baseline mentation may not be known. Okay, one thing to do is never assume that they've got altered mental state just due to their age. Consider some of the other potential causes, because some of our oldies that are into their 90s and even above are completely sharp and really with it, and quite often it's an easy mistake to make when they're presenting with confusion or a delirium that's because of their age. Okay, so find out from the relatives as soon as you can, what are they usually like? Are they usually confused? Is this confusion new? Because it may be hypoxia that you're seeing rather than, dementia with it. Never assume that it's dementia unless we can confirm it through the relatives. Do listen to their relatives. Their thermoregulation is less efficient, and lab studies are really an essential part of their assessment to really know what's happening with them. We have the challenges of pain relief, because we certainly don't know what their kidney and liver function's like for them to be metabolising that, so pain relief needs to be done safely for them, and also anaesthesia issues with them. Children also present their own little challenges as well. When we do their airway breathing circulation, it's keeping their head in a neutral position, because they've got those, certainly young children have got those really lovely large occiput in relation to their body. Okay, so we don't want to extend them back too far. It's keeping them in a neutral position to maintain their airway. And with the older children, they call it the sniffing the morning air. If you sort of stretch out and have a little sniff of the air, that's the sort of positioning that they're wanting to get them in to be able to maintain their airway. Blood pressure can be well maintained despite significant hypovolemia. So what happens with their little young ones is their bodies are compensating so well, and they'll compensate, crash on us. Okay, so it's really at quite a late stage that we're seeing that drop in blood pressure, and when it is happening, we know that they really are compromised. The other thing is need to know what are the normal parameters for the different age groups for their vital signs. Okay, I don't work with kids that often, so it's not something that necessarily I can get off the top of my head, but if you are working with children, it's something that you certainly need to know. The other thing is if they're coming through with spinal injuries, because of the elasticity of their bones, they can actually have a spinal cord injury that's not obvious on X-ray or on plain films, and that's known spine without any radiological abnormalities. Okay, and it's snapped out of place, spinal cord has been severed. Okie dokes, thank you. And then it's snapped back into position, looks absolutely fine on X-ray, but you're seeing a patient that's got spinal deficits through. The other thing to remember is that they've got really elastic chest walls, so when you are seeing rib fractures, it implies a significant amount of force to be able to do that to a young patient. So really suspect that there's things that are going on under those ribs. They've got a lot less developed muscles of their abdominal wall, so they've got a lot less protection around their abdomen. Bones are much more pliable, so you see quite different injury patterns that we can see in adults, and also they have their own challenges with analgesia and how they react to it as well. So in conclusion, it's really good to have a systematic approach to get the best outcome for our patients, and certainly our colleagues in emergency department, we can learn a lot from them with the way that they organise and prioritise their care in that initial stage. In trauma, there's 3 phases that we're really at risk. First of all, from the immediate trauma. The immediate trauma, I've just gone off track, haven't I? That first minutes to hours, and also the complications that we have further along the stage. But when we're managing them, 3 phases is that immediate, identifying things that are life-threatening and then limb-threatening, putting in that emergency treatment for the patients, and then later coming along and doing the much more definitive treatment and starting our rehabilitation for our trauma patients. Priorities for assessment and resus are the same for children and adults, but the differences in anatomy and also their physiological responses to trauma are things that we must consider when we're looking after these patients. And the approach to dealing with trauma has evolved along with understanding of our physiological and our inflammatory responses to injury. So certainly understanding things much more about the stress response and also about the second hit and the insults that we're causing to their inflammatory response has changed the way that we deal with their injuries. So it's looking at that staged approach to surgical management in the multiply injured patient to try and minimise the impact and not compromising a lot more by what we're doing. Okay, so thank you. What I'll do is stay around now in case you have any questions on any of the stuff that I've done. I know stress response is really quite a difficult subject. My postgrads have a lot of trouble getting their heads around it. So it's something that you probably need to read and get your head around on your own with that. But it's just giving you a little bit of a taster of letting you know a little bit about it and how that impacts on our orthopaedic patients. So if you have any questions, then let me know. Thank you.
Thanks, Wendy. That was great. It was really interesting. Has anyone got any questions or comments for Wendy? No questions. I've got an interesting story I would like to tell about assessment, and I think towards the I got bumped off a couple of times. There was something weird going on with my internet. Sorry, but I think you were talking about assessing the patient and looking at the whole patient. And I remember once we had a patient admitted to ortho. They were actually admitted after a overdose or a suicide attempt with medication, and he came into the ward and he was dressed, and at one stage, about half an hour later, he wanted to go to the toilet, so we got him up and we noticed that he had this big burn on his leg, and we couldn't work out how, he didn't come in with any trauma or anything, but what had happened was he'd overdosed. The day was so hot, and I think you were talking about environment, that he was unconscious on the ground, and it was 40 degrees or something, and he'd actually had a full thickness burn to his leg just from laying on the bitumen where he'd collapsed.
Oh, goodness.
And no one had actually looked at that in ED because he was an overdose, he wasn't anything else, and so it wasn't until he was on the ward maybe 3 hours later that we'd actually noticed that. So that always sticks with me, that assessment example.
Yeah, and hence that importance of the rolling them and having a look once we've got them stable enough to be able to do that, because that's certainly very important. That makes me think of the syndromes as well with the overdose patients, where they've had a limb that's been trapped under them as well. We've, had a few of those too.
Miriam asking a question about warm fluids for resuscitation in ED. Do you know if that occurs?
Okay, I don't actually work ED at the moment, but it is my understanding that I think that they do. I can confirm that for you, but my understanding would be, because I know that they always talk about the mixture of, a hypovolemic patient, as well as a hypothermic patient, and the mixture of those two as being just so dangerous, for the patient. So hypertensive, hypovolemic, hypothermic, there's certainly things that they're wanting to manage with that. We actually have a postgrad lecture coming up on fluid resus, so we'll know, but that's not till August. So but I can confirm that for you with that. I don't know if anybody else wants to answer what they're doing in their clinical area with that as well.
Yeah, I don't know personally. That would be an interesting question to find out.
Yeah, because certainly, you would think, with that mix that would help as well. Christian's just saying his internet was dodgy as well. Have you guys got a bit of weather happening over there?
Yeah. It's a bit dodgy at the moment, yeah.
Yeah, and Paul will be getting that YouTubed and put on our website. And, so you can certainly look at it back or recommend it to any of the staff that you think may benefit from that as well. Ah, right, okay. Looks like we'll all have to move out to the eastern suburbs. I know Victoria's got some horrible weather at the moment.
Miriana's